Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 246 of our pharmacotherapy series, which majors in infectious diarrhea. The first question reads, BSC is a 49-year-old obese woman, presenting to the emergency department with a 1-week history of fever, confusion and delirium, severe abdominal pain, headache, anorexia, and diarrhea and, for the past 1 day, a red rash on her chest. Her history of present illness is significant for returning 10 days ago from travel to the Indian subcontinent where she stayed with relatives, some of whom were recovering from typhoid fever. BSC's medical history is significant for gallstones. She lives in California with her husband. Admission vital signs show a temperature of 101 degrees Fahrenheit, a heart rate of 60 beats per minute and a stable blood pressure. Physical examination is significant for a toxic-appearing female with a red rash on her chest, splenomegaly, and hepatomegaly. Laboratory tests include the following. WBC is 3.0 times 10 power 6 per microliter. Liver function tests are mildly elevated, and the results of 2 sets of blood cultures are pending. BSC is given the presumptive diagnosis of severe enteric fever and encephalopathy, most likely attributable to Salmonella typhi. Why is her history of present illness, clinical presentation, and laboratory results consistent with this diagnosis? A key piece of information from BSC's history of present illness supporting the diagnosis of typhoid fever is her recent travel to the Indian subcontinent where typhoid fever is endemic, and her contact with relatives recovering from this infection. Other developing countries with endemic typhoid fever include Southeast Asia, Africa, and Latin America. In developed countries, enteric fever is a sporadic disease occurring mainly in travelers returning from areas where the disease is endemic. In the United States, 85% of cases of typhoid fever are travel-related. BSC's clinical presentation and laboratory findings are classic for enteric fever. During the 7 to 14-day incubation period, Salmonella multiply within macrophages and monocytes, and systemic manifestations of infection appear after the release of bacteria into the bloodstream. Patients usually present with fever, abdominal pain, anorexia, diarrhea or constipation, headache, dry cough, splenomegaly, and hepatomegaly, while severe illness is characterized by concomitant GI bleeding, encephalopathy, and shock. Bacteremia may be followed by localized infection to the liver, spleen, bone marrow, gallbladder, and Peyer's patches of the terminal ileum. Laboratory abnormalities consistent with typhoid fever include BSC's low WBC count and mildly elevated liver function tests. The next question reads, would BSC benefit from a course of antimicrobials to treat her presumptive diagnosis of typhoid fever? If so, what options are available? BSC would benefit from effective antimicrobial treatment for typhoid fever in the following ways. 1. Shortening the resolution of fever from 3 to 4 weeks to 3 to 5 days, with clearing of all symptoms within 7 to 10 days. 2. Decreasing mortality from usually 5% to 10% to less than 1%. 3. Eradicating fecal shedding of Salmonella typhi, thereby limiting further spread of infection. And 4. Preventing relapse of infection. Most cases of typhoid fever are effectively treated with oral antimicrobials. IV therapy is reserved for severely ill patients or patients with persistent vomiting and severe diarrhea. Chloramphenicol, TMP-SMX, or ampicillin. Until the late 1980s, typhoid fever was cured in more than 90% of patients treated with 14 to 21 days of chloramphenicol, TMP-SMX, or ampicillin. By the early 1990s, multidrug resistant, i.e., simultaneous resistance to chloramphenicol, ampicillin, and TMP-SMX, Salmonella typhi caused outbreaks of typhoid fever in Asia and Africa. Fortunately, these multidrug-resistant isolates remained susceptible to the fluoroquinolones, which then became the antimicrobials of choice. Interestingly, there has been a reduction in multidrug-resistant Salmonella typhi to as low as 12% in some areas of the world. Regarding fluoroquinolones, short treatment courses, that is less than 5 days, of oral fluoroquinolones were once as effective or better than previously used treatments, e.g., TMP-SMX, ampicillin, or chloramphenicol. By the late 1990s, short-course fluoroquinolone therapies used in parts of Asia were associated with clinical failures in up to 50% of patients. Microbiologic evaluation revealed these isolates were resistant to nalidixic acid and had higher ciprofloxacin MICs, 0.125 to 1 microgram per milliliter, compared to Salmonella that was fully susceptible to ciprofloxacin MICs of less than 0.03 micrograms per milliliter. Catafloxacin, a newer generation fluoroquinolone, no longer marketed in the United States, with lower MICs compared to ciprofloxacin, 0.19 versus 0.5 micrograms per milliliter, respectively, cured greater than 95% of children with typhoid fever, most of whom were infected with nalidixic acid-resistant Salmonella typhi. In areas with a high prevalence of nalidixic acid-resistant Salmonella typhi, alternatives to fluoroquinolones include azithromycin and selected third-generation cephalosporins. Next we will discuss azithromycin. Azithromycin is effective for patients with mild to moderate typhoid fever. Azithromycin, dosed at 20 mg per kilogram per day, for 7 days cured greater than 95% of children with uncomplicated typhoid fever in Vietnam, where 96% of Salmonella typhi are nalidixic acid resistant. Fever clearance time was 106 hours and there were no relapses. In contrast, lower azithromycin doses, that is 10 mg per kilogram per day, in the setting of nalidixic acid resistance are associated with lower cure rates, 82%. Concerning is the identification of azithromycin-resistant Salmonella typhi and non-response to azithromycin. Next we will discuss beta-lactams and tigecycline. Cefixime, an oral third-generation cephalosporin, is variably effective for the treatment of typhoid fever. Failure rates range from 4% to 27% and some experts do not recommend its use for the treatment of typhoid fever. The lower clinical response to cefixime may be related to the poor intracellular penetration of the beta-lactam because the intracellular compartment is the primary site of Salmonella typhi colonization. Ceftriaxone, an intravenous third-generation cephalosporin, is recommended for the treatment of severe typhoid fever with the caveat that longer treatment courses are recommended to prevent relapse of infection. In patients with bacteremia caused by ceftriaxone-susceptible isolates, relapse of infection was higher among patients treated with a 7-day course of ceftriaxone versus azithromycin, 14% versus 0%, respectively. No relapses were reported when a longer course, lasting 14 days, of ceftriaxone was used for infection caused by multidrug-resistant Salmonella typhi. Patients treated with ceftriaxone may remain febrile for as long as 10 days. Ceftriaxone-resistant Salmonella typhi have been reported in India, the Philippines, China, the United States, and elsewhere. Potential alternatives to ceftriaxone include carbapenems, such as imipenem cilastatin, meropenem, and ertapenem, and tigecycline, though clinical data are lacking. The next question reads, what specific empiric antibiotic regimen would you recommend for the treatment of BSC's complicated, severe typhoid fever? How would her treatment differ if she had uncomplicated typhoid fever? For complicated typhoid fever, empiric therapy with ceftriaxone is recommended. Once susceptibility data are available, treatment options include 10 to 14 days of ceftriaxone, dosed at 1 to 2 grams IV once daily, continued for at least 7 days after defervescence to minimize the risk for relapse, or a fluoroquinolone for 10 to 14 days. Uncomplicated typhoid fever is typically treated in the outpatient setting. Empiric oral regimens include azithromycin 500 mg daily for 5 to 7 days, or a fluoroquinolone, e.g., levofloxacin 500 mg once daily or ciprofloxacin 500 mg twice daily. For children, azithromycin or ceftriaxone is recommended. Interestingly, with the reduction in MDR Salmonella typhi in some areas, ampicillin, amoxicillin, TMPSMX, or chloramphenicol are again options for susceptible isolates. The next question reads, besides the administration of antibiotics, what adjunctive therapies could benefit BSC for the treatment of severe typhoid fever? Enteric encephalopathy, i.e., altered mental status, is associated with a mortality rate as high as 56% if effective treatment is not promptly administered. In patients with enteric encephalopathy, retrospective data report improved survival when appropriate antimicrobial therapy is combined with high-dose dexamethasone 3 mg per kg IV followed by 1 mg per kg every 6 hours IV for 8 doses. The mechanism of action of dexamethasone in enteric encephalopathy is not known. The next question reads, 14 months after discharge from the hospital, BSC remains free of symptoms associated with typhoid fever, but follow-up testing reveals she continues to excrete Salmonella typhi in her stools. Additionally, their adult son, who has dinner with them every Sunday, presents to his clinic doctor with fever, headache and chills, and is confirmed to have uncomplicated typhoid fever. He has no significant past medical history and has no recent travel history. How might her son have acquired typhoid fever? What treatment recommendations can be provided to this family? Unlike his mother, BSC, her son has no travel history to an area where typhoid fever is endemic. Instead, he is likely to have contracted typhoid fever from consuming foods prepared by his mother, who is now a chronic carrier of Salmonella typhi. Most patients with typhoid fever continue to excrete Salmonella typhi in their stools for 3 to 4 weeks after recovery from their illness. However, 1% to 3% of persons like BSC become chronic carriers who continue to excrete Salmonella from stool or urine for more than 1 year after infection and serve as reservoirs for spreading infection. Unlike for non-typhoidal Salmonella, humans are the only natural host and reservoir for Salmonella typhi. BSC's risk factor for becoming a chronic carrier is her history of gallstones, which allows the sequestration of organisms within her abnormal biliary tract. The next question reads, what therapeutic options are available to cure BSC's chronic carrier state? Treatment options for chronic Salmonella typhi carriers like BSC include a prolonged course of antibiotics, cholecystectomy, or suppressive antimicrobial therapy. 50 to 90% of chronic carriers may be cured after prolonged courses of antibiotics, although efficacy may be lessened when anatomic abnormalities, e.g., cholelithiasis, are present. Relapse is usually detected within the first several months after completing antimicrobial therapy but can occur up to 24 months after completing therapy. For susceptible Salmonella typhi, curative oral antimicrobial regimens include amoxicillin 2 grams 3 times daily for 28 days, ampicillin 1 gram 4 times daily for 90 days, ampicillin 1.5 grams 4 times daily plus probenecid for 6 weeks, TMP-SMX 160/800 mg twice a day for 3 months, ciprofloxacin 500 to 750 mg twice a day for 3 to 4 weeks, or norfloxacin 400 mg twice daily for 4 weeks. The next question reads, BSC's sister is planning a trip to the Indian subcontinent and is concerned about acquiring typhoid fever. So my question to you is, what can she do to reduce her risk for becoming infected? The U.S. Centers for Disease Control and Prevention recommends vaccination for travel to areas where the risk for Salmonella typhi is increased, including many Asian, African, and Latin American countries. In the United States, 2 licensed vaccines are available to protect against Salmonella typhi but not against Salmonella paratyphi. The intramuscular vaccine for persons older than 2 years of age is 55% effective in preventing typhoid fever. Its adverse effects include local pain and swelling, fever, and headache. The oral live attenuated vaccine TY21A vaccine, which is a series of 4 doses for persons older than 6 years of age, is well tolerated, and it affords a protective efficacy rate around 55%. Since the oral vaccine is a live attenuated vaccine, it should not be administered to immunocompromised persons. Additionally, to ensure full vaccine activity, the live attenuated vaccine should not be given until at least 3 days after the last dose of an antimicrobial, and if possible, antimicrobials should not be initiated within 3 days of the last dose of the oral vaccine. Longer intervals should be considered for long-acting agents such as azithromycin. Finally, because the protective efficacy of available vaccines against Salmonella typhi is not 100%, and because neither vaccine is licensed to protect against Salmonella paratyphi, which in some Asian countries accounts for up to 50% of blood isolates from patients with enteric fever, it is still necessary to reinforce the importance of good hygiene and the avoidance of foods with a high risk for being contaminated with enteropathogens. The next question reads, MOT is a 60-year-old, ill-appearing man hospitalized for bloody diarrhea and fever. 2 days before admission he noted the onset of fever, abdominal cramps, and 6 to 7 non-bloody, watery stools. His diarrhea has since worsened to 10 to 12 small volume stools with blood and mucus, and he now complains of painful straining while passing his stools. His history of present illness is significant for returning 3 days ago from a business trip to Indian subcontinent. During the business portion of the trip, he remained at the hotel where all his meals were prepared by hotel staff well trained in the sanitary preparation of foods. However, on the day of his departure he opted to mingle with local residents to get a first-hand taste of native foods and beverages from street vendors. MOT lives alone in Florida, has no significant medical history or drug allergies, and takes no medications. On admission, his temperature is 101 degrees Fahrenheit and physical examination reveals a critically ill man with severe abdominal tenderness. Why is MOT's history of present illness and clinical presentation consistent with the diagnosis of dysentery, most likely caused by Shigella dysenteriae type 1? MOT's diagnosis of dysentery, likely caused by Shigella dysenteriae type 1, is consistent with his recent travel to the Indian subcontinent where Shigella dysenteriae type 1 is both epidemic and endemic primarily as a consequence of inadequate systems for disposal of sewage. MOT likely became infected from the consumption of contaminated foods or beverages prepared by local street vendors, by person-to-person contact with symptomatic persons with diarrhea, or from asymptomatic persons continuing to excrete Shigella from their stool. As few as 10 to 100 Shigella can cause illness in healthy hosts, explaining why Shigellosis is a very contagious infection. Once ingested, virulence factors allow Shigella to evade detection by the immune system and invade colonic and rectal epithelium. Enterotoxin production causes fluid secretion into the intestinal lumen and cytotoxin production causes cell death. Both toxins lead to the severe clinical manifestations of Shigellosis. As with MOT, within 24 to 48 hours after ingestion of Shigella bacteria, symptoms of dysentery begin and include fever, fatigue, malaise, and anorexia. Watery diarrhea generally precedes dysentery, and frequently is the only manifestation of mild infection. Progression to dysentery may follow within hours to days and is characterized by frequent, small volume, bloody, and mucoid stools, abdominal cramps, and tenesmus, which is described as painful straining when passing stools. Hemolytic uremic syndrome, abbreviated as HUS, is a serious complication of Shigellosis, occurring in up to 13% of patients with dysentery caused by Shigella dysenteriae type 1. HUS is a consequence of the production of Shiga toxin 1, most commonly produced by Shigella dysenteriae but also rarely by Shigella flexneri. Longer-term health complications of diarrheal illness caused by invasive pathogens like Shigella species, as well as Salmonella and Campylobacter species, include post-infectious irritable bowel syndrome or reactive arthritis. The next question reads, would MOT benefit from antimicrobials to treat the bloody diarrhea and fever, that is dysentery, presumably caused by Shigella dysenteriae type 1? For several reasons, MOT would benefit from antimicrobial therapy for dysentery presumably caused by Shigella dysenteriae type 1. First, effective antimicrobial therapy reduces the average duration of illness from 5 to 7 days to about 3 days and reduces the risk of death and serious infection-related complications. Within 48 hours of starting treatment, MOT should notice a reduction in stool frequency, volume of bloody stools, and fever. Second, effective antimicrobial therapy quickly reduces the carriage and excretion of Shigella, thus limiting the spread of infection. Despite the aforementioned benefits of antimicrobial therapy, there has been concern that antimicrobials could increase the risk for developing hemolytic uremic syndrome. However, Benish and colleagues reported that early administration of effective antimicrobials, i.e., within 3 to 4 days of the onset of dysentery, is associated with a low risk for developing hemolytic uremic syndrome. The next question reads, what empiric antimicrobial regimens are available for the treatment of Shigellosis? Shigella species are well known for rapidly developing resistance following exposure to antimicrobials, therefore, selection of empiric therapy should be based on local antimicrobial susceptibility patterns. Regarding ampicillin, TMP-SMX, and nalidixic acid, during the 1960s to 1980s, ampicillin, TMP-SMX, or nalidixic acid were the standard treatments for shigellosis. During the 1990s, multidrug resistant, i.e., resistance to ampicillin, TMP-SMX, and chloramphenicol, Shigella precluded their empiric use for shigellosis, but as these multidrug-resistant isolates remained susceptible to fluoroquinolones, these agents became the drugs of choice for this infection. Regarding fluoroquinolones, in adults, oral ciprofloxacin 500 mg twice daily for 3 to 5 days is effective against multidrug-resistant Shigella dysentery type 1 infection in the setting where all isolates are susceptible to ciprofloxacin and nalidixic acid. With the widespread introduction of fluoroquinolones as the drugs of choice for the treatment of shigellosis, not unexpectedly, quinolone-resistant Shigellae have emerged. Ciprofloxacin resistance in Shigella species from Asia and Africa has progressively increased from 0.6% prior to 2000 to 29.1% during 2007 to 2009. Although the prevalence of ciprofloxacin-resistant Shigella remains low, that is less than 5%, in Europe and America, international travel is strongly associated with the importation and subsequent circulation, within the United States, of ciprofloxacin-resistant Shigella sonnei and other multi-drug-resistant Enterobacteriaceae. Regarding azithromycin, in the setting of epidemic dysentery caused by Shigella dysentery type 1, similar clinical outcomes were observed in adults treated with a single 1 gram oral dose of azithromycin or multiple doses of ciprofloxacin 500 mg orally twice daily for 3 days. In this study, the mean number of days until resolution of symptoms after starting therapy was similar, 2.5 days for azithromycin versus 2.3 days of ciprofloxacin, but only 17% of isolates were nalidixic acid resistant. In adults with moderate to severe shigellosis caused by multidrug-resistant Shigella species, clinical efficacy is similar with oral azithromycin 500 mg on day 1, then 250 mg daily for 4 days, or oral ciprofloxacin 500 mg every 12 hours for 5 days, 89% versus 82%, respectively, with a p-value greater than 0.2. In a subgroup analysis, a greater proportion of patients infected with Shigella dysentery type 1 failed therapy with either azithromycin 29% or ciprofloxacin 17%, compared with patients infected with other Shigella species, failure rate of 6% for either antibiotic. Nearly all, 97%, of the Shigella dysentery type 1 isolates were nalidixic acid resistant, median ciprofloxacin MIC of 0.125 micrograms per milliliter, whereas only 6% of other Shigella species were nalidixic acid resistant, median ciprofloxacin MIC of 0.016 micrograms per milliliter. Concerning is the intercontinental spread through sexual transmission of azithromycin-resistant shigellosis and treatment failure following azithromycin therapy. Shigella sonnei with reduced susceptibility to azithromycin remains susceptible to ceftriaxone, and ceftriaxone has successfully treated a patient with azithromycin-resistant shigellosis failing azithromycin therapy. Beta-lactams. The oral third-generation cephalosporin cefixime is unreliable for the treatment of shigellosis, with failures reported in 11% to 47% of patients. Parenteral ceftriaxone and cefotaxime have excellent in vitro activity against Shigella species and have been used alone or with amikacin for patients failing ciprofloxacin therapy. Though uncommon, ceftriaxone-resistant Shigella have been reported in Asia. Ongoing surveillance to detect changes in antimicrobial susceptibility among Shigella species is needed to direct local empiric treatment recommendations. The next question reads, should loperamide be started in patients with dysentery? The role of antimotility drugs in patients with dysentery has been debated, the concern being that prolonging the clearance of pathogens from the intestinal tract could worsen the severity of illness. However, loperamide, in combination of ciprofloxacin, has been safely used in non-critically ill adults with bacillary dysentery primarily caused by Shigella species, decreasing the number of unformed stools and shortening the duration of diarrhea. Fever was not prolonged in these patients. However, the authors stressed that all Shigella isolates in the study were susceptible to the antimicrobial used, i.e., all isolates were susceptible to ciprofloxacin and nalidixic acid, and none of the patients were critically ill. Thus, it would not be prudent to extrapolate the findings from this study to critically ill patients like MOT. The next question reads, what empiric antimicrobial regimen could be started in patients like MOT with severe dysentery, likely caused by Shigella species? Ciprofloxacin, azithromycin, and ceftriaxone are the primary agents used for the treatment of shigellosis, though resistance to all of these agents has been reported. In the setting of severe dysentery associated with nausea and vomiting, parenteral ceftriaxone is a reasonable empiric option. Fluoroquinolones are a less desirable option given the widespread prevalence of fluoroquinolone-resistant Shigella species in areas including the Indian subcontinent where MOT likely became infected. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 247.